Hi, my name is Kylie Harris. Thank you for joining me for my presentation today. I'd just like to really thank Elizabeth Sabet and the conference organisers for allowing me to do a pre-recorded presentation. I'm joining you today from Tasmania in Australia, and I'm just going to start sharing my screen so that I can share my slides with you. So today I'm going to be presenting some research that formed part of my PhD research. The research project was called Spiritual Emergency, Psychosis and Personality, investigating the role of schizotypy. And as well as myself as an author, my supervisors and co-authors are Adam J. Rock and Gavin I. Clark. So I'd just like to acknowledge them today as well. I'd like to begin by acknowledging the traditional custodians of country throughout Australia and their continuing connections to land, waters and culture. We pay our respect to their elders past, present and emerging, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So just a little bit about me. I'm a research psychologist, a writer and an activist from Australia. My academic work focuses on the interface between spirituality and mental health. I'm a member of the Emergent Phenomenology Research Consortium and a founding board member for the Australian Centre for Consciousness Studies. So I'm just going to start by defining some of the key terms that I'll be using throughout the presentation. Spiritual emergence is the first. So Groff and Groff described spiritual emergence as the movement of an individual to a more expanded way of being that involves enhanced emotional and psychosomatic health, greater freedom of personal choices, and a sense of deeper connection with other people, nature, and the cosmos. Spiritual emergency is another term I'll be using a lot throughout the presentation. So a process of spiritual emergence may become an emergency or crisis if an individual does not possess the psychological framework with which to cope with the experience. Importantly, spiritual emergency has been associated with both physical and mental health difficulties, while also simultaneously providing a unique opportunity for transformation and growth. So when we look at the relationship between spiritual emergency and psychosis, researchers have found that psychosis exists as a continuum in the general population. And some other researchers and authors have proposed a spiritual psychosis continuum. So like spirituality at one end, psychosis at the other, and various phenomena in between. In some previous research that I did with my co-authors, we found that participants described experiences ranging from general spiritual awareness and experience, so for example, mystical and paranormal phenomena, through to severe psychological crises manifesting symptoms that received a clinical diagnosis. So that is, some participants reported experience that met the objective criteria for clinical psychosis, yet they self-identified their experience as spiritual emergency. And some of these participants felt that their experience should not necessarily have been pathologized in the way that it was. So when we look at psychotic symptoms, as they are defined by the Diagnostic and Statistical Manual of Mental Disorders, otherwise known as the DSM, psychotic symptoms are generally broken down into positive and negative dimensions. There is also disorganized dimension, which I will go into a little bit later, but when we look at the positive and negative dimensions, we've got for positive symptoms, we've got delusions, which refer to rigidly fixed beliefs despite conflicting evidence. Hallucinations are described as perceptual experiences that occur in the absence of external stimuli. Disorganized thinking is inferred from disorganized speech. Grossly disorganized or abnormal behavior is described as child, silly-like behavior and catatonia. Then when we look at the negative symptoms, we've got restricted emotional expression, which is described as diminished facial and emotional expression. Avolition is described as a lack of motivation towards self-initiated purposeful activities. Alogia refers to diminished speech output. Anhedonia refers to decreased ability to experience pleasure. And asociality refers to a lack of interest in social interactions. So this is the way that the DSM defines these symptom domains, and essentially they use behavioural observation to define and make these diagnoses. So theoretically and anecdotally, spiritual emergency has been associated with clinical psychosis. So for example, schizophrenia and bipolar disorder and other types of psychotic disorder. as well as other psychological disorders such as depression and anxiety. There's also things like PTSD, that sort of thing. This relationship has also been supported empirically, and previous research indicates that spiritual emergency may be associated with the positive symptoms of psychosis, but not the negative. So this is an important aspect of what my research will unpack. So when we look at the relationship between spiritual emergency and personality, measuring schizotypy, which is a personality construct, which refers to, is basically, well, I'll just explain. Measuring schizotypy allows researchers to assess psychosis proneness, so a proneness towards the development of clinical psychosis. But measuring schizotypy as a personality trait allows us to look at this in non-clinical populations. And this is based on the premise that psychosis is quantitative and may manifest at subclinical levels as a personality trait. So this basically means that schizotypy can be viewed as a personality trait that might predispose someone to develop psychosis, but that, you know, people can have levels of schizotypy and not necessarily develop psychosis or be pathological in any way. So when we look at the schizotypy factors, they're very similar to the psychosis factors or dimensions. So we've got positive schizotypy, which corresponds to the active symptoms of psychosis, such as unusual perceptual experiences, ideas of reference, magical thinking, and paranoid ideation. And we've got the negative symptom domain, which corresponds to those symptoms of psychosis that represent introverted or absent behaviour, such as the inability to feel pleasure from social or physical stimulation, social anxiety, and a lack of interpersonal relationships. We've also got disorganised. So I didn't go into the disorganised symptoms of psychosis, but when we look at the disorganised symptoms of schizotypy, they also correspond with the disorganised symptoms of psychosis. So this includes odd behaviour and speech, and disorganised forms of thinking, such as a tendency for thoughts to become derailed. There are some other symptom domains, but those are the three main ones that we look at. And those are the three that I've looked at in my research. So both positive and negative schizotypy have been associated with psychotic symptoms and predict the development of psychotic disorders. So again, it doesn't mean that if you are high on either positive or negative schizotypy that you are psychotic or that you will develop psychotic disorder as it is defined by the DSM. But statistically speaking, you are more likely to develop psychotic disorder. It's a very contentious topic, and that's why this research is so important. However, the positive and negative symptoms of schizotypy are associated with the development of differential patterns of symptoms and impairment. So, for example, positive schizotypy has been more likely to be associated with thought impairment, mood disorders, anxiety, and depression, whereas negative schizotypy is more likely to correspond with emotional disturbance, affective flattening, and social impairment. When we look at the relationship between schizotypy and spirituality, studies have revealed a positive association, so a positive relationship between positive schizotypy and spiritual belief and experience, spiritual connectedness, paranormal belief and experience, extraterrestrial and UFO-related beliefs, and transliminality. So transliminality refers to a hypothesized tendency for psychological material to cross thresholds into and out of consciousness. So it's been associated with things like loose boundaries, temporal lobe lability, even epilepsy, I believe, but also with creativity. So many studies have failed to find a relationship between negative schizotypy and spiritual and related phenomena. So again, the research seems to suggest that there's a relationship between the positive symptoms of schizotypy and spiritual experiences, but not necessarily between negative schizotypy and spirituality. Healthy schizotypes. This is a concept that refers to the uncoupling of the concept of schizotypy from the concept of disease. So in the research, in the literature, there are kind of two camps of people who are investigating schizotypy. There are those who conceptualize schizotypy as a pathological personality trait that is inherently problematic. But then there are others who view schizotypy more as, I guess, like a deviant personality trait that may predispose to the development of psychosis, but that should not be considered pathological in and of itself. So some researchers called Nettle and Clegg have suggested that negative schizotypy scores may differentiate healthy schizotypes from those who develop a disorder due to the disorganizing effects of positive schizotypy. So they're suggesting that it's whatever level of negative schizotypy people have, that's what determines how pathological their experience might become. So they have suggested that a combination of high positive and low negative schizotypal symptoms may enable an individual to channel their schizotypal tendencies into adaptive creative endeavours. And they've also suggested that people who demonstrate high positive and high negative, so high on both dimensions, may be more likely to suffer from psychological disorder. Some other researchers, Schofield and Claridge, have suggested that the more cognitively disorganised an individual is, the more likely they are to be overwhelmed and distressed by anomalous experiences. So disorganised schizotypy generally involves cognitive functioning deficits such as semantic processing, visual backward masking, working memory, and emotion processing. So these things are often impaired if someone is high on disorganised schizotypy. And fluctuations in positive schizotypy may result in fluctuations in disorganised schizotypy, resulting in fluctuations in the subjective interpretation of psychotic-like experiences. So that sounds a bit complicated, and what it means is that if someone is experiencing a combination of positive schizotypy and disorganised schizotypy, and these are kind of fluctuating in relationship to one another, then this can influence how someone subjectively perceives experiences that may be considered psychotic-like, such as those associated with positive schizotypy. Some other researchers, Linney et al., conducted a twin study and found that both positive and negative schizotypy are genetically related to disorganised schizotypy. So they found a biological genetic link between all three dimensions of schizotypy. And they suggested, so I guess a little bit differently to the previous researchers who were focusing on negative schizotypy as being sort of a deciding factor, these researchers have suggested that disorganised schizotypy may be at the core of a tendency towards schizophrenia. So they're really focused on the disorganised dimension as being really key to, I guess, what we consider pathology. They've also suggested that the disorganised dimension of psychosis has been most strongly related to genetic liability for psychotic symptomatology and has been associated with a history of past admissions and a longer lifetime duration of inpatient treatment. So again, we're seeing this kind of relationship between schizotypal symptoms and psychotic symptoms in this sense, with a focus on disorganised schizotypy and psychosis as being kind of central to the development of psychotic-like symptoms and cases of diagnosed psychosis that have a poor prognosis. So these authors also suggested that different aspects of disorganised schizotypy may be differentially related to positive and negative schizotypy. For example, they suggest that the social anxiety aspect of disorganised schizotypy may be genetically related to negative schizotypal traits, whereas the disorganisation aspect of disorganised schizotypy may be genetically related to positive schizotypal traits. So you've kind of got this breakdown of like different aspects of the different dimensions. They keep getting broken down further and further, and they're sort of differentially related to the other symptom domains. Another researcher called Matheson proposed that disorganised schizotypy may lead to the emergence of paranormal beliefs and experiences, which are characteristic of positive schizotypy. So for cognitively disorganised individuals, unexpected and disturbing events may challenge their existing belief system, creating a struggle to integrate the experience, otherwise known as a paradigm shift for the individual. And he suggests that disorganised and positive schizotypy may reinforce one another, so kind of may act in a bidirectional manner. So if one is high on disorganised schizotypy, that they might also be high on positive, and that these might then interact to reinforce one another. He also suggested that disorganised schizotypy may be the core contributing dimension to the expression of psychotic-like experiences. So that assertion is in line with the previous researchers who were focused more on the disorganised aspect of schizotypy as being really central to the expression of psychotic-like experiences. So for the current research, based upon the literature that I've just unpacked, we aimed to explore the relationships between spiritual emergence, spiritual emergency, psychosis, and personality. We hypothesised that spiritual emergency would be positively correlated with positive psychosis and schizotypy, and that it would demonstrate either negative or no correlations with negative psychosis or schizotypy. We also hypothesised that disorganised schizotypy would mediate the relationship between positive schizotypy and crisis associated with spiritual emergency, so focusing on the subjective interpretation of a spiritual emergency experience. And similarly, we hypothesised that positive schizotypy would mediate the relationship between disorganised schizotypy and crisis associated with spiritual emergency. So we decided to go down this line of looking at positive and disorganised schizotypy as kind of interacting with one another and reinforcing one another, and having an influence on how somebody would subjectively perceive their experience of spiritual emergency. So for our method, we had 250 participants and they were aged 18 to 85, so quite a large age range. They completed an anonymous online questionnaire, and we managed to gather participants from quite a wide range of geographic locations. So you can see in the table here, most participants were from Australia and New Zealand, but we also had quite a few from Europe, from the Americas, and some from Asia and Africa. In terms of the materials that we used, we put together a composite questionnaire, which was used to measure a number of variables, including psychological crisis, which was measured using the crisis state assessment scale, spiritual emergency and crisis. We measured this in 3 ways. So 2 of the ways I'll unpack a bit later on, but one of the scales that we used was an already established questionnaire called the spiritual emergency scale. And then we looked at the symptom domains of psychosis and schizotypy. So looking at these positive, negative and disorganised aspects. So for symptom domains of psychosis, we use the community assessment of psychic experiences. And for schizotypy, we use the Oxford-Liverpool inventory of feelings and experiences. So for the spiritual emergency measurement, as I said, we use the spiritual emergency scale as one way of measuring spiritual emergency. But then we also referred back to some previous research that we had undertaken, which was some qualitative research where we were able to come up with some themes and some really rich descriptive data that we used to construct kind of a working definition of spiritual emergency. So for this research, for this previous research, participants were asked to indicate, for the current research, participants were asked to indicate the degree to which they self-identified with the following definition of spiritual emergency. And this definition was based on this previous research. So what we came up with for a definition was that spiritual emergence and emergency refers to a process of integrating spiritual awareness and experience, for example, mystical and paranormal phenomena, unusual emotional and physical sensations, which generally facilitates positive transformation and growth. However, if the process occurs very rapidly or is triggered suddenly, such as via a traumatic experience, it may become unmanageable and an individual may experience states of crisis involving psychological distress, coping difficulties, and a lack of understanding by self and or others. And when we look at spiritual emergence becoming emergency, severe cases may exhibit symptoms commonly diagnosed as clinical psychosis. So we ask participants to read that definition and then record on a visual analog scale, which is kind of like a line that has, we used a line that went from 0 to 100, and so on that line, we have 0 representing not at all, so they didn't identify with that experience at all. 100 meant that they identified with that experience very much. And participants could mark anywhere along that scale to what degree they identified with that experience. And so they were told that they didn't have to identify with the entire experience, with every aspect of it, but they could identify, very strongly with only one aspect, but not others. So there was kind of a lot of freedom in how they could self-identify, because one of the important aspects that I wanted to bring into the research was the concept of ownership of one's experience. So the concept of sort of shifting away from the concept of diagnosis from an external perspective and really giving someone a sense of ownership over their own experience. So really asking people, this is our definition of spiritual emergency. How much do you identify with that? So in terms of our procedure, ethics approval was granted by the University of New England Ethics Committee, where my PhD was undertaken. The participants completed an anonymous online questionnaire. Participants quantified their experience of spiritual emergency on a visual analog scale, as I just described. They were, again, as I just explained, they were informed that they were not required to identify with the experience. So some people could not identify at all, and some of the participants did not identify at all, so they would mark 0 on the scale, as we were seeking individuals across the entire spiritual emergency spectrum, and they were told that they could identify with some aspects of the experience only. And so again, there was a lot of freedom in terms of, you know, somebody might identify very, very strongly with only one aspect, and they could mark, you know, they could mark 100 on the visual analog scale, even though they were only identifying with a tiny aspect. So there was that whole sense of ownership over the experience. Participants then completed the crisis state assessment scale in relation to the definition of spiritual emergency. So this is more clearly explained when you read the research paper, but basically what this aspect was in order to measure our third spiritual emergency variable, which we termed spiritual crisis, we used a combination of people's responses on the visual analog scale for spiritual emergency and how strongly they self-identified with that. And then we asked them to complete the crisis state assessment scale in relation to the definition of spiritual emergency, so that we could then create this variable spiritual crisis, which was a combination of their responses on the visual analog scale and their responses to the crisis questionnaire. We put those scores together, and then that variable became spiritual crisis. Participants then completed the spiritual emergency scale, the CAPE and the O-Life, which were the measures of psychosis and schizotypy. So for our results, we performed some correlation analyses, and what we found was that the spiritual emergency scale displayed statistically significant, moderate to strong positive correlations with the positive symptoms of psychosis and schizotypy, and it displayed weak positive correlations with the negative symptoms of psychosis, but no association with the negative symptoms of schizotypy. We also found that this variable spiritual crisis displayed statistically significant, moderate positive correlations with the positive symptoms of psychosis and schizotypy, and weak positive correlations with the negative symptoms of psychosis and schizotypy. Whereas our spiritual emergency variable, which was the variable where participants were self-identifying with the definition of spiritual emergency, this variable displayed statistically significant moderate positive correlations with the positive symptoms of psychosis and schizotypy, and no associations at all with the negative symptoms of psychosis or schizotypy. So that's what we were predicting. So the hypothesis that spiritual emergency would be positively correlated with positive psychosis and schizotypy, but not with negative psychosis and schizotypy, was partially supported. And it was partially supported because one of our 3 spiritual emergency variables did fulfill that criteria, and that was the spiritual emergency variable, whereas the first 2 partially supported in the sense that they did show stronger relationships with the positive symptoms, but they did also show some small relationships with the negative symptoms. So I will unpack that as we go further along. We also conducted some mediation analyses. So mediation analysis is a statistical method used to evaluate a proposed causal relationship between an antecedent variable X and a consequent variable Y via an intervening variable M. So it is assumed that M is causally located between X and Y. So just as a caveat, while this was not a study that could definitively establish causal relationships, it's still possible to use statistical techniques that are kind of based on these assumptions, as long as you're very transparent and upfront about what it is that you're measuring and how you're measuring it. So while we could not establish causality, what we could look at was the possibility of causality. So we're looking at variable X causing variable Y, but having like a third variable M, which is kind of like a part of that relationship, influencing that relationship. So from the mediation analyses, we found that the relationship between positive schizotypy and crisis, so positive schizotypy and that subjective interpretation of the experience, was mediated by disorganized schizotypy. And we also found that bidirectional relationship, which we were looking at, that the relationship between disorganized schizotypy and crisis was mediated by positive schizotypy. So the hypothesis that a bidirectional relationship exists between positive and disorganized schizotypy, leading to crisis, so leading to that subjective interpretation of the experience as being a negative one, was supported. That hypothesis was supported. So when we get into our discussion, the spiritual emergency scale and the spiritual crisis variables in the study were designed to measure spiritual emergency experiences and their associated degree of psychological crisis. So both of those variables were intended to bring in the crisis aspect. And both of those variables were correlated moderately to strongly with the positive symptoms of psychosis and schizotypy. But, well, as I said, one the spiritual emergency scale did not associate with schizotypy, whereas the spiritual crisis variable did. Both showed weak correlations with negative symptoms of psychosis, and the spiritual crisis variable showed weak correlations with negative schizotypy as well. However, the spiritual emergency variable in the study, which was the one where participants were asked to self-identify with the definition, this was not designed to capture crisis associated with these experiences. So this one was not bringing in that kind of aspect of crisis. It was more just, here is our definition of spiritual emergency. How much do you identify with that? We weren't kind of assessing whether that was entirely subjectively positive, entirely subjectively negative, or some combination of the two. And so this variable demonstrated moderate to strong correlations with the positive symptoms of psychosis and schizotypy, and no relationship at all with either the negative symptoms of psychosis or schizotypy. So these results suggest that spiritual emergency experiences are associated with the positive symptoms of psychosis and schizotypy, and their association with negative symptoms of psychosis and schizotypy appears only to manifest to small degrees if there is associated crisis. So to unpack this a bit further, it's been suggested that negative psychotic symptoms may represent safety behaviours to avoid the exacerbation of positive symptoms. That is, negative symptoms, which tend to be indicative of pathology and poorer outcomes, may manifest as a defensive reaction to a lack of validation and erroneous diagnosis by mental health professionals towards individuals presenting with positive psychotic and schizotypal symptoms. So what that means basically is that the positive symptoms, as we predicted, the positive symptoms of psychosis and schizotypy were associated with spiritual emergency experiences. And while we predicted that they would not be associated with negative symptoms, we found that there was a small association with the negative symptoms, but only when that experience of crisis was present. So this kind of like this supports this contention by these previous authors who have suggested that the negative symptoms really start to manifest and show themselves as safety behaviours. So these negative symptoms really only start to come in as the person gets kind of further along that continuum of feeling crisis, so feeling like subjectively negative about the experience. So what the suggestion here is that basically the person doesn't need to manifest these negative symptoms if the experience is regarded in a validating way. So the negative symptoms appear to manifest when the person is feeling defensive, like they're experiencing these positive symptoms, they're kind of not being given the opportunity to explore the positive symptoms. They may have been given a clinical diagnosis of schizophrenia, bipolar, some other kind of psychological illness, and that's when we start to see the negative symptoms emerge. So the negative symptoms are kind of like, yeah, like they come up as a kind of a last expression of the experience when the person is starting to feel really stressed and starting to slip into crisis. So these results support previous findings that have shown positive associations between spiritual and paranormal belief and experience, and positive but not negative schizotypy. And the results also indicate that individuals scoring high on positive psychotic and schizotypal characteristics may be self-identifying their experience as a spiritual emergency with or without the presence of psychological crisis. So what that means is that individuals who do score high on these positive symptoms A lot of these individuals in our study were also self-identifying their experience as spiritual emergency. So they weren't necessarily considering their experience as pathological, because a lot of these people did not necessarily score high on crisis. So, you know, we had some participants who scored really high on the spiritual emergency variable, but they scored really low on crisis. So they were experiencing a high level of positive symptoms, or, you know, what we would consider symptoms, positive characteristics of schizotypy and psychosis, but they weren't experiencing crisis. Like they weren't experiencing their experience as a negative thing. It comes down to like the subjective interpretation that others are putting on their experience. So that is, the presence of positive symptoms alone do not necessarily indicate pathology. Indeed, negative and disorganized symptoms are more likely to be associated with a poor prognosis. So what the previous research demonstrates is that it's negative and disorganized symptoms that are more likely statistically to be associated with longer hospitalization, poorer outcomes, a life history of mental illness, and that the presence of these positive symptoms, they don't necessarily indicate pathology. And that's what our research supported. As such, these results provide further support for the continued revision and reconceptualization of diagnostic criteria to ensure that individuals self-identifying with the experience of spiritual emergency are not erroneously diagnosed with schizophrenic or psychotic disorders. So what we're proposing is that these research findings, they really support they support the continued revision of the current diagnostic system, because, basically the current diagnostic system means that a lot of these people, a lot of the people who participated in our research would fulfill the diagnostic criteria for a psychotic disorder. And what we're proposing is that that is not necessarily an accurate representation of people's subjective experiences. And so we propose that the current diagnostic system needs to be reevaluated. This finding is important because the positive symptoms of psychosis alone are currently sufficient to warrant a diagnosis of schizophrenia spectrum disorder, for which current conventional treatment often involves psychopharmacological interventions. So currently the DSM diagnostic criteria for schizophrenia requires an individual to demonstrate either hallucinations or delusions, which are both positive symptoms. And the presence of those symptoms alone are sufficient to diagnose schizophrenia. So spiritual emergency experts have cautioned that inappropriate use of medication may impede the natural transformative process of the experience. So a lot of people who would fulfill this criteria for schizophrenia, not only are they told that they are ill, they're often hospitalized and medicated, sometimes against their will. And what we're suggesting is that this is not okay, and that this diagnostic system needs to be looked at to reflect the current day subjective experience that people are reporting. So current empirically derived guidelines outline spiritual and religious competency practices for psychologists. However, since the inclusion of the DSM-V code, religious or spiritual problem, clinicians have not been using the code or receiving adequate training in religious and spiritual competencies, despite acknowledgement of the importance of spiritual assessment. So Lukoff and colleagues back in the 90s developed a DSM-V code, which is kind of like a supplementary code for clinicians, which is included in the DSM. It's called religious or spiritual problem. And the impetus behind the development of this V code was the author's knowledge of spiritual emergency and associated phenomenology, and the fact that a lot of clinicians were not aware of these experiences, didn't have training in them. So these authors worked really hard to get this V code included in the DSM. However, unfortunately, it kind of sits there in the background. There's not a lot of training that goes on for clinicians to understand or know how to use the code. A lot of practitioners don't even know about the code's existence. And this is despite the fact that there is continual, updating of competency practices for psychologists that really highlight the need to have a look at individuals' spiritual and religious practices. So the results indicated that cases of diagnosed clinical psychosis and psychotic-like experiences that exhibit a higher degree of positive than negative symptoms may be differentiated from more malignant forms of psychosis that have a poor prognosis. Such experiences may be considered as a possible spiritual emergency experience and may be best treated using an alternative framework, such as that used within the Soteria paradigm. So the Soteria paradigm is a transpersonal approach using a spiritual emergency framework. It's been used in several healing centres, treatment centres around the world. And so, yeah, what the results suggest is that it is the expression of the positive symptomatology rather than the negative that can kind of help to differentiate between cases of diagnosed psychosis that you know, I mean, some cases of diagnosed psychosis might do better with medication. Yeah, this is something that needs to be unpacked further through research. So, you know, we don't want to claim that all cases of clinical psychosis are spiritual emergency. We're being a bit more conservative than that, and suggesting that some cases or most cases potentially may be best treated using a spiritual emergency approach. And it really comes down to, I guess, the degree of positive versus negative symptoms that people are reporting. But what our research does support is that when people are expressing a higher degree of positive symptoms, then we should definitely be looking at or exploring the idea of using a more transpersonal approach and considering the fact that the person might be experiencing spiritual emergency as opposed to these forms of psychosis that do tend to have poorer outcomes, statistically speaking. So the results did reveal a bidirectional mediation effect between positive and disorganized schizotypy, leading to crisis associated with spiritual emergency. So that is, disorganized schizotypy mediated the effect between positive schizotypy and crisis, and positive schizotypy mediated the effect between disorganized schizotypy and crisis. So as I kind of explained earlier, we did find support for this idea of a kind of an interaction, like a bidirectional relationship between positive schizotypy, disorganized schizotypy. If people are high on both, and these two dimensions are kind of interacting with one another, they can reinforce one another. And this can then influence how someone subjectively perceives their experience, especially when they are identifying their experience as being spiritual emergency. So this supports the contention that the more cognitively disorganized an individual is, the more likely they are to be overwhelmed and distressed by anomalous experiences. That is, disorganized schizotypy appears to influence the subjective interpretation and appraisal of spiritual emergency experiences. So the more that someone is experiencing that sense of kind of overwhelm, that cognitive disorganization that leads to like cognitive load, cognitive overwhelm, then the more likely they are to become overwhelmed and distressed if they do experience these positive symptoms of schizotypy. So while the contribution of negative schizotypy requires further exploration, these findings indicate that individuals who demonstrate high levels of positive and disorganized schizotypy, irrespective of negative schizotypy, so we kind of didn't end up focusing too much on negative schizotypy, we were more interested in the positive and disorganized aspects. So those individuals demonstrating high levels of positive and disorganized schizotypy may be at risk of experiencing the potentially debilitating effects, so experiencing that state of crisis that is associated with spiritual emergency. And the findings support cognitive models of trauma and psychosis, indicating that if an individual exhibiting a positive schizotypal personality perceives anomalous phenomena, which is characteristic of positive schizotypy, so those things like magical thinking, unusual experiences, unusual perceptual experiences, that kind of thing, when an individual experiences those things as traumatic or distressing, associated deficits in the cognitive processing of incoming stimuli, so associated deficits in like how that information is processed, so i.e. disorganized schizotypy, may result in a state of psychological crisis that is characteristic of both spiritual emergency and clinical psychosis. So we're saying that, you know, trauma is associated with spiritual emergency and clinical psychosis if these two things are in fact different, which we're not saying that they are, but we're not saying that we're not. What we're saying is that trauma is inherent to these experiences, and that what our research supports is that kind of the more cognitively disorganized someone is, the more chance they have of interpreting these types of experiences as something that is difficult and overwhelming for them. The findings also support the idea that disorganized schizotypy may be at the core of psychotic-like experiences, such as the other researchers that I explained earlier, focusing on the idea that it's disorganized schizotypy that really kind of helps to define these psychotic-like experiences. And if this predisposition facilitates the negative subjective appraisal of positive schizotypal phenomena, such as that commonly associated with spiritual emergency, an individual's belief system may become challenged, creating a struggle to integrate the experience, otherwise known as an individual paradigm shift. So, again, what we're saying here is that if this predisposition to disorganized schizotypy, if this predisposition facilitates that kind of like negative interpretation of the positive schizotypal phenomena. So if someone is experiencing hearing voices or, you know, communicating with entities, for example, if someone is experiencing this type of phenomena, which is commonly associated with positive schizotypy, and they're also feeling really disorganized, cognitively disorganized, then their existing belief system can become overwhelmed, it can become challenged. They have to then kind of reconcile this experience, which is, sort of what contributes to the state of crisis, because all of a sudden the person's worldview is thrown into turmoil. And this creates that real psychological struggle for them, which essentially, you know, represents a paradigmatic shift in their psychological makeup. So if we look at Matheson's hermit crab syndrome, he suggests that if an individual is unsuccessful in establishing such a paradigm shift, so if they're unsuccessful in reconciling this experience, which involves a cognitive restructure of their existing belief system to integrate the experience, then he suggests that that's when psychotic symptoms may result. So basically, you know, if someone is having one of these experiences that they self-identify as spiritual emergency, they're feeling really overwhelmed, they're finding the experience really challenging. If they don't manage to successfully integrate that experience, then this is when people may be more likely to, I guess, slide further along that spectrum into what is considered to be clinical psychosis. So therefore, it appears that the subjective interpretation and appraisal of anomalous experiences is key in the development of pathological psychotic-like experiences, so what we would consider to be clinical psychosis, versus the successful integration of the experience. So that is the successful integration being a successful cognitive paradigm shift, and the achievement of positive transformation, with cognitive disorganization playing a significant role. So to unpack that a little bit, we're saying that, that we agree that cognitive disorganization is potentially the key factor in these experiences, and that when someone is experiencing the types of anomalous experiences that are characteristic of positive schizotypy, so if someone is experiencing unusual perceptual phenomena, if they feel that they're hearing voices, if they've got certain, you know, magical beliefs, for example, it's the subjective interpretation of these experiences that really influences their ability to successfully integrate the experience. And this is really largely influenced by the feedback that they get from other people. So the study was not without limitations, and some of those limitations include the fact that we had a self-selected convenience sample. We provided data through self-report measures. The clinical implications of the findings are limited by the use of a non-clinical sample. The results are potentially limited by different cultural interpretation of scale items. So while we did have quite a large, culturally diverse sample, which could be perceived as a positive thing, there could also be a flip side to that, in the sense that there might have been some kind of cultural language barriers in terms of how they interpreted the scale items. Some of our variables were non-normally distributed, so that means that we need to interpret the results with caution. And as I explained earlier, mediation analysis is not conclusive with regards to causation. It gives us kind of an indication that causation might be present, but we can't conclude from the results of this research that one thing causes another. So with those limitations in mind, some suggestions for future research include the need to differentiate between past versus present experiences of spiritual emergency. So we kind of just did like a cross-sectional, I guess, analysis of whether, to what degree people identified the spiritual emergency. But what we didn't ask them was, do you feel that you're currently experiencing spiritual emergency, or do you feel that you have previously experienced it? And so for future research, I think this is really, really important to unpack, because it kind of has implications for what we might expect to see with regards to that subjective interpretation. So for example, if someone was currently experiencing a spiritual emergency, then they're probably going to be in a current state of crisis. And so they're probably experiencing or appraising their experiences in a negative way because they're in a current state of trauma. Whereas if they had previously experienced spiritual emergency, then they're more likely to have potentially integrated the experience to some degree, and potentially have achieved that sense of transformation and growth that is characteristic of the experiences. So we didn't do that in this study, and that was just beyond the scope of the study, but that is something that I think is really important to look at down the track. We also propose to explore the developmental etiology of cases of self-identified spiritual emergency and compare that to cases of clinically diagnosed psychosis, particularly those with a long history of psychopathology. So, we would like to ideally look at, cases that are characterised by the negative symptoms as well as the positive, and have a look at that entire spectrum of, people who have had long histories of being in and out of the mental health system, had various diagnoses, different levels of trauma, for example. So it would be good to kind of have these different groups of people and do some comparative analyses on that. Additionally, comparative analysis of treatment modalities that have demonstrated efficacy in the treatment of both spiritual emergency and clinically diagnosed psychosis. So we would like to do some comparative analysis of the different treatment modalities, like, for example, pharmaceutical interventions, the soteria paradigm, for example, where they do use a more holistic transpersonal approach. And there is evidence suggesting that transpersonal approach can result in at least potentially equally beneficial outcomes, potentially more beneficial outcomes, and certainly without the use or without the need for the use of high degrees of pharmacological interventions. So that would be important to look at. We also suggest some follow-up analyses using clinical samples. So as I said, our sample is just a general population sample, but it would be really useful to have a look at some clinical samples as well. So people who have actually been formally diagnosed with these various forms of psychosis. We'd like to do some comparative analysis across different cultural groups. So to address this potential issue of cultural interpretation of the scale items, it would be really great to work with, people from different cultures and have them potentially, reword items or just make sure that the scale items were appropriate for the particular cultural group that we're looking at, and then compare those different cultural groups to see if spiritual emergency is like a universal phenomena, or if it's, for example, more of a Western-bound phenomena, for example. We also suggest the adaptation of scales to foster cultural sensitivity and diversity. That's basically what I just explained. And in order to address this issue of causation, we recommend experimental and/or longitudinal study designs so that we can try to understand, these relationships from a causal perspective. At the moment, we're looking at them just from a relational perspective, but if we could establish some sense of causality, that would be useful. So here are just a list of my references. I can be contacted via email. You can email me directly and I can provide a PDF copy of the research for you to read, which obviously goes into a lot more detail than what I've been able to do here. It is quite a complex paper. I find it difficult to read myself, to be honest. It's a complex paper. We look at kind of a lot of variables. There's lots of use of these words of positive and negative, and they can be a little bit confusing. So if anyone wants to read the paper and then has any follow-up questions, please feel free to get in contact with me. You can also find me on various social media platforms. I'm not prolific on social media. I don't really have the time or the inclination, but what I do is I pin to the top of my profiles either current projects or projects that are deemed to be important. So if you do jump on social media and look me up, Dr. Kylie Harris, you will find updates and anything that is kind of central to the work that I'm doing at the moment will be pinned to the top of those pages. So please do feel free to jump on there and follow me and have a look at what's going on and contact me if you've got any questions. So I think I've still got a few minutes left for this presentation. I know the presenters are doing 45-minute presentations because this is a pre-recording. Elizabeth has asked me to kind of do roughly an hour. So because I finished early, I just thought maybe people might be interested to hear a little bit about what inspired the research project. So I can go into that a little bit to add that sort of personal dimension to the research. So basically I undertook this research project while after I had just had my son. So I had had quite a traumatic childbirth experience, and part of that experience for me involved a high amount of positive schizotypal characteristics. I personally do score very highly on schizotypy, in particular the positive dimension. And so my son's childbirth, my childbirth experience with my son was very traumatic, and it did bring up a lot of what would be considered positive symptoms of psychosis, of schizotypy and probably psychosis. So for example, I was experiencing a lot of images that might be perceived as past life imagery, for example. I experience a high degree of unusual perceptual phenomena, such as voice hearing, what would be considered auditory hallucinations, for example. And during this time, I was trying to finish my PhD, and it was quite stressful. And what I was finding was that, I'm sure my husband won't mind me mentioning this, but he's quite cognitively disorganized. He hasn't received any formal diagnosis, but as a psychologist, I would consider him to demonstrate quite high levels of ADHD type phenomena. And so what I found was that during this time of doing this research project, I was experiencing a high level of positive symptomatology, and also feeling really disorganized and feeling like when I was in a situation that exacerbated that sense of cognitive disorganization. So when my husband is kind of being really disorganized, when the house is a mess, and when my physical surroundings are quite disorganized, it makes me feel disorganized. Like when you're in a messy house, it makes your mind feel messy. And so what I was realizing was that for me personally, it was this combination of positive symptoms and disorganized symptoms that really seemed to work together to make me feel like I was in a state of crisis. It really did make me feel, crazy, for want of a better word. And so I do work very experientially. So meaning that my research is very much guided by my personal experience. So again, that could be considered a limitation in the sense that there could be some researcher bias involved in the project. But again, I think as long as you're transparent and upfront about these things, then that's the best I can do, really, because I think being guided by your own personal experience is probably key to undertaking research. But for that reason, I do strongly encourage other researchers to adopt the methodology that we used for this project, because I think, it's really important to have replication studies and for people to objectively study these things as much as we can. But that was basically my personal experience and how that really influenced what I felt was important to study. And we obviously tried to undertake the research in as objective a way as possible, by being transparent about the whole process. We've written the paper in a way that people can replicate it really easily, using the questionnaires that we used, using the methodology that we used. And so I would love to work with other researchers who are interested in replicating the study, because I do think that the implications are quite important. Well, very important, really, in the sense that it was the first study to look at this personality dimension of psychosis. So it was the first study to look at the different symptom domains of schizotypy and really break down those symptom domains and look at them in relation to the psychotic symptom domains and also people's subjective identification with spiritual emergency. So in that sense, the research was quite unique. And I would really love to work with others who are interested in exploring this phenomena, using statistics to explore it, because that is something that has been largely missing from the spiritual emergency literature, is the use of robust statistical analyses to test some of these theories. And so, again, please feel free to reach out to me. I love to answer questions. I love to meet with people. I'd love to work with anyone else who is interested in working in this area. And especially people who are guided by their personal experiences, because I think that's really important to bring that personal element into the research and then to explain it to people so that it doesn't just seem dry and clinical. It's coming from a perspective of, hey, I'm an experiencer too. I've never received a formal diagnosis, but I think that's just because for whatever reason, I seem to have protective factors that allow me to be quite functional, even when internally I don't feel very functional at all. So during the undertaking of this research project, I was not feeling particularly functional, but what I did was I really made the work my therapy. And so I also encourage other researchers to do that as well, make the work your therapy. And I guess that's where the activism comes into it, in the sense that as an experiencer, I empathize, I relate to other people who are having these experiences, and I feel really strongly about unpacking them further, using methodology, using language that enables me to get the research published in peer-reviewed journals, to present the research at conferences like this, and just to speak to people to help validate these experiences for people, because anecdotally, they are happening more frequently. And I think that there is a lot that can be, I guess, drawn out of this type of research in terms of looking at the parallels between what happens on the individual level and what happens on the collective level. And so transpersonal researchers and writers have been talking for a long time about the concept of a global spiritual emergency. I do personally believe that we are in that right now. And so experiencing or investigating these experiences on the individual level, which is what this research project does, it does have implications for how we might be able to generalize these findings on a more collective level. So, we're suggesting that a combination of positive schizotypal symptoms and disorganized schizotypal symptoms are what really contribute to that state of crisis on an individual level. When we look at that on a collective level, it requires obviously empirical research to validate, but we could potentially hypothesize that that collective on that collective level, higher levels of positive schizotypal symptoms. So higher levels of, things like voice hearing, communicating with spiritual entities, these types of kind of spiritual beliefs and practices, when you've got high levels of those in the community, and then you've got high levels of basically disorganization, which again, we're seeing with issues like COVID, with climate change, which is kind of stirring the pot and creating a lot of societal unrest. Collectively, we're seeing the combination of these symptoms. We're seeing the combination of people experience or collectively experiencing this combination of positive schizotypal and psychotic symptomatology and disorganization. And so that potentially is a recipe for a collective spiritual emergency. So I think that's also something that can be, drawn out of research like this, and then used as a foundation to explore on a scientific level. So I will leave it there. Thank you again so much, Elizabeth and the rest of the ACISTE team, for allowing me to do this pre-recorded presentation while I relocate myself and my family to Tasmania, Australia's island state, which has been incredibly healing. Thank you everybody for watching and listening. Please do reach out to me. I would love to speak with people, and I hope you enjoy the rest of the conference. Thank you.